Thank you for joining us. My name is Audrey Hassan, patient liaison for the MDS Foundation, and I'll be moderating the presentation today. As we get started, I would like to thank Acceleron, Bristol Myers Squibb, Gamida Cell, Jazz Novartis, and Takeda for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Yazan Madanat, an assistant professor at UT Southwestern Medical Center in Dallas, Texas. He earned his medical degree at the University of Jordan and completed his residency training in internal medicine at the Cleveland Clinic in Cleveland, Ohio. Drawn by the opportunity for harmonious integration of clinical medicine, pathophysiology of disease, and novel treatment approaches, he completed his hematology and medical oncology fellowship at the Cleveland Clinic with clinical and research focus on myeloid malignancies, myelodysplastic syndromes, myelodysplastic myeloproliferative neoplasms, and acute myeloid leukemia. Dr. Madanat's decision to come to UT Southwestern was influenced by the multidisciplinary care provided in their malignant hematology and bone marrow transplantation department. He currently directs the myelodysplastic syndromes program. His clinical research interest lies in understanding the molecular and genomic drivers of disease and to better understand ways to incorporate novel therapies for his patients. He has delivered several presentations and published numerous academic articles and book chapters that focus on the treatment of myeloid malignancies, acute leukemia, and myelodysplastic syndromes. Dr. Madanat brings to UT Southwestern a strong background in malignant hematology and currently specializes in the treatment of patients with myelodysplastic syndromes. His clinical practice emphasizes a personalized approach in a patient and family-centered care. With that said, it is my pleasure to introduce Dr. Madanat.
Hi, everyone, and thank you for joining us today. My name is Yazan Madanat, and I'll be talking to you today about the factors to consider in the initial treatment approach for myelodysplastic syndromes. So I'm in Dallas currently, and I am an assistant professor at UT Southwestern Medical Center, part of and I run the MDS program here. Again, thank you for joining us, everyone. Let's get started. So here are my conflicts of interests. And the outline for our talk today, we'll start by going through the definition and epidemiology of MDS, and then go through some of the pathogenesis and how to make a diagnosis of MDS, and then delve into the factors that impact my decision-making for the treatment of my patients with MDS, looking at the MDS subtype, the disease classification, the prognostic risk score of MDS, whether it's lower risk disease or higher risk disease, patient factors to consider, whether it's age, other medical conditions, preferences and desires, and then what are the goals of therapy for each of the MDS risk scores. And then we'll highlight some of the management and the FDA-approved therapies in lower and higher risk MDS, and also highlight some of the exciting clinical trials that are currently ongoing in MDS. So how would you define MDS? And if you look in any medical book, the definition is quite cumbersome and is defined as a heterogeneous group of malignant clonal hematopoietic stem cell disorders characterized by ineffective hematopoiesis, dysplastic changes, and the risk of transformation to acute myeloid leukemia. This is a pretty long and confusing definition, and the simple way I define MDS is that it's a bone marrow cancer. So our patients with MDS need to know that they have a bone marrow cancer and need to approach it as such as a pretty big issue that can affect their quality of life, morbidity, and mortality. MDS was defined as a cancer not too long ago, back in 2001. And if we look at the epidemiology, we have about 13,400 new cases that are diagnosed per year. and the incidence is about 5 per 100,000 population, with a slight male preponderance or slight male increased male to female ratio for MDS diagnosis. The incidence, however, increases with age, and if we look at patients in the Medicare database, so patients older than the age of 65, we notice that about 75 per 100,000 population can have a diagnosis of MDS, so much higher than what's been previously reported across all age groups. MDS is definitely a disease of our older population. The median age at diagnosis is 77 years, and this is based off of the most recent updated SEER data. The 5-year overall survival for MDS, just to put it in context as compared to other types of cancers, is about 31%, and this encompasses all subtypes of MDS for all patients. But as you can notice, this is worse than the prognosis for myeloma, colorectal cancer, chronic myeloid leukemia, amongst others. And so it needs to be dealt with as such. So MDS is an issue with hematopoiesis. And what hematopoiesis is the way our blood-forming stem cells in the bone marrow grow, mature, and then form the healthy, mature cells that do their function. So we have two big families in the bone marrow, the myeloid family and the myeloid stem cells, and then the lymphoid family. And MDS, or myelodysplastic syndrome, is derived from abnormalities in the myeloid stem cell. And so those myeloid stem cells produce eventually the healthy and grown white cells, amongst which are the neutrophils that we always focus on and talk about that fight the bacterial infections, the erythrocytes, or the red blood cells, which carry oxygen to our body and tissues, and then the platelets, which prevent bleeding. And so issues can arise from having a diagnosis of MDS is that those myeloid stem cells aren't really making the healthy grown blood cells that they should be making. And so a drop in neutrophil count may lead to increased risk of infection. A drop in the hemoglobin or the red blood cell count may lead to symptoms of anemia like fatigue, lightheadedness, blurred vision, tiredness, and then a drop in the platelet count can lead to increased risk of bleeding. And so increased risk of infection, increased risk of bleeding are the two main risk factors that our patients with MDS face, in addition to the symptom burden that comes largely from having low red blood cell count or being anemic. So does making a diagnosis of MDS need a bone marrow biopsy in 2020? And the simple answer is yes. And the reason for that is in the bone marrow, we need to identify those abnormal looking cells or dysplastic cells. So the myelodysplastic syndrome, you can divide it into 3 portions. The myelo is the myeloid family in the bone marrow that's affected. The dysplastic or dysplasia or dysplastic changes can affect one or all 3 cell lines in the erythroid, the red blood cell forming cell line, the megakaryocytic or platelet forming cell line, and then the granulocytic or white blood cell forming cell line. So the things that we look at in a bone marrow biopsy are how much dysplasia do we have, or how many abnormal cells can we count under the microscope? And this is what our pathologists do and help us make the diagnosis. In addition, they look for certain immature cells called blasts in the bone marrow, and these are the immature white blood cells. And if those increase in number, that makes the MDS a higher risk. And if they increase in number more than 20%, then we call the disease acute leukemia. And so knowing the percentage of blasts at diagnosis is really crucial and important to help us with the risk stratification. And then there is a specific subtype of cells called ring sideroblasts that occur in about 1/3 of patients with MDS. And these are important to know because there's now in 2020 a treatment that's approved for patients who have MDS with those ring sideroblasts. And those are iron deposits around the cell that make that ring formation. And we can see it here on the right-hand side of the slide with those bluish ring around those red cells. The other thing that can make a diagnosis of MDS, if we don't see any of these, is a defining cytogenetic abnormality. So which brings us to what are the cytogenetics, or what are chromosomal abnormalities. So a chromosome is basically our DNA and genetic material. And those chromosomes are present in the nuclei, or the nucleus of our cells. Each chromosome has two arms and two legs, so to say. The upper two arms, we call them the P arms, which are the short arms, and then the longer Q arms, or legs. So these can sometimes be either, some of them can be missing or added. And so these chromosomal abnormalities usually drive the MDS and lead it to develop with time. So these defining cytogenetic abnormalities can occur as the cells are dividing. So in the nucleus, on the top figure A, there we have our 23 pairs of chromosomes. So 23 chromosomes come from mom, 23 from dad, and that makes up our 46 chromosomes. And these usually, when the cells are dividing, line up in the middle of the cell and then are split into two because there is a pair of each chromosome. Once they're split, sometimes as a result of the cell division, certain chromosomes can become stuck and others can become lost during this process. And once in a while, this chromosomal abnormality can give the cell a growth advantage. And this is commonly what happens in MDS. So knowing the chromosomal analysis at diagnosis is really important. That sometimes can help us make a diagnosis of MDS, but also can impact the risk of the MDS itself. And then the last portion from the bone marrow or the peripheral blood is the genomic landscapes, or the gene abnormalities that are driving MDS. And we know that in about 90% of patients, they have at least one genetic abnormality or a gene mutation that's driving the MDS. And the most common ones are the TET2 mutation, the SF3B1 mutation, ASXL1 mutation. SF3B1 is a splicing mutation that's important to know upfront if someone has this mutation in their MDS cells, because there's also a treatment that's approved for this specific subtype of MDS, and that's called Luspatercept, which we'll be talking about in further detail through the presentation. So the factors that impact my treatment decision for MDS is, what is the MDS subtype or classification? What's the WHO or the World Health Organization disease classification? What's the prognostic score of the MDS? Is it a lower risk disease or is it a higher risk disease? And those are thought of as two separate kind of entities and are approached very differently. And then what are the goals of therapy? And most importantly, what patient factors do we take into account in terms of medical comorbidities, what's my patient's age, and what are their preferences, and how do they want us to approach their MDS? So coming to MDS subtypes, what do I need to know upfront in order to classify the subtype of MDS correctly according to the WHO classification? I need to know from the pathologist how many cell lines are dysplastic, or how many cell lines look abnormal. Are the red cells, the white cells, and the platelets all affected, or is it one of these cell lines? And then on the chromosomes, do I have a deletion 5q, or is one of the legs of chromosome 5 missing, and is this the only chromosomal abnormality? What is the blast percentage in the bone marrow as the pathologist looks at all of these cells, counts them under the microscope, and gives us a percentage? What is that percent, and how does it factor into my treatment decision? And then do we have this SF3B1 mutation, which correlates usually with having the ring sideroblasts on the bone marrow cells? All of these factors, knowing them, will help me classify the MDS disease into one of these risk categories. I group them together on the left side because they can be a little bit confusing. What's more important to me is, again, do we have those ring sideroblasts? How many cell lines have the dysplastic changes? Do we have the missing leg of chromosome 5, so to say, or the deletion 5q abnormality? And are the blasts more than 5%? If you notice on the right-hand column, the bone marrow blast percentage for most MDS subtypes are less than 5%, except for the MDS with excess blast 1 and MDS with excess blast 2, which is MDS EB1 or MDS-EB2. Why is it important to know these? Because when we have a higher blast percentage, then usually we're dealing with a little bit of a more higher grade or rapidly growing disease for the most part. And in that case, usually we're dealing with a higher risk disease. So what allows or opens treatment options for us is the presence of this SF3B1 mutation, which correlates with the ring sideroblast, and that's where luspatercept has been approved, and the presence of deletion 5q abnormality in which lenalidomide is FDA approved. So these two kind of disease subtypes are important to help open some treatment options for my patients with MDS. And then coming to the prognostic risk score of MDS, do I have a lower risk disease or do we have a higher risk disease? And these are defined based on the International Prognostic Scoring System, or the IPSS, which was first devised in 1997 and then later revised in 2012. Both scoring systems, or the revision, really encompass three major factors. What are the blood counts, that neutrophil count, the absolute neutrophil count, the hemoglobin number, and the platelet count? What is the bone marrow blast percentage, and what chromosomal abnormalities do we have? So those three factors, blood counts, bone marrow blasts, and chromosomal abnormalities, will help us calculate the IPSS or the revised IPSS scores and help us determine whether the MDS risk is of lower risk or of higher risk. So this is the IPSS scoring system. And the reason I put this is because it's a complicated score. And I usually go back to these tables whenever we're calculating the risk score of the MDS. And so each cytogenetic or chromosomal risk group can be good, intermediate, poor risk. Bone marrow blasts, depending on what the blast percentage, that as the blasts increase, that increases the risk score. And then depending on the number of the low blood counts, whether it's the ANC, the hemoglobin, or the platelets, that also increases the risk score of the MDS. And then once we plug in these scores, we add them all up together and then come up with a final score. And that brings us to risks categories. Low and intermediate 1 usually are considered lower risk disease, and then intermediate 2 and high risk are considered higher risk disease. The reason for that is the survival for patients with MDS with lower risk is much different than the survival for patients with higher risk. And once that score has been revised, we focus more on the actual number for the hemoglobin, the actual number for the neutrophil count, and the actual number for the platelet count. And then once we put everything together, the revised version has 5 different risk categories. And as you can see, in terms of how long our patients live with MDS, that can vary anywhere between less than a year to up to 10 years. And that's average, right? So average survival, meaning in 9 years for patients in a specific risk score, about half of those patients will be alive. And that means that half may not make it to 9 years, but also half can make it past that time point. And those scores were really devised for patients with MDS who just got supportive care and didn't have any active therapy. And so we hope to improve on those outcomes by intervening and introducing therapy. So these prognostic risk scores, and how do they factor with my treatment decision making? So for lower risk MDS, and that's defined by having a low or intermediate 1 risk IPSS, or a value low risk or intermediate risk revised IPSS score. And typically we have the MDS with a low blast percentage, less than 5% in the bone marrow, whereas my high risk MDS comes usually in the intermediate 2 or high risk disease per the IPSS, intermediate, higher, and very high risk per the revised IPSS. And on morphology, usually the bone marrow blasts are higher, are 5% or higher, and the higher risk of the MDS. Coming to goals of therapy, and what do we hope to achieve for patients who have lower risk MDS? The ultimate goal is to really improve those blood counts and decrease the transfusion requirements and the transfusion burden that the patient is needing. And by by doing that, hope to improve the quality of life and the symptom burden so that our patients are feeling better and living the best quality of life possible. We know that the only curative option for MDS is an allogeneic transplant, which is a transplant that's from a donor stem cells. And then the last factor in terms of the goals of therapy is when to initiate therapy for patients with lower risk MDS. And I always consider the following two factors. What are the blood counts? How low are they? And how is the patient feeling? So if a patient feels well and the blood counts aren't terribly low where they don't need any blood transfusions, they don't need platelet transfusions, and they don't have any infections, observation and really following those blood counts closely and close monitoring usually is very appropriate and works quite well. However, when we come to higher risk MDS, it's really important to note that the patients with higher risk MDS are at higher risk for the disease to progress to acute myeloid leukemia or acute leukemia. And the survival is greatly shortened when we have a higher risk MDS as opposed to lower risk MDS. And therefore, doing therapies to prolong survival and prevent the disease from going to acute leukemia are really the two goals that we hope to achieve. And again, similar to lower risk MDS, the only curative option is an allogeneic transplant. And we want to really try and consider that for as many patients as we can. And lastly, coming to our patient factors. So what are the comorbidities and how do these factor in our decision making? These really impact our decision largely when we're talking about transplant consideration. There is a comorbidity risk score or comorbidity index that takes into account every single organ system and whether we have any previous medical conditions that may make the transplant a higher risk procedure where it's not justifiable for our patients with MDS. And so we look at the heart, the gut, the kidneys, the lungs, the liver, and really every organ system, and then come up with a total score. And the higher the score based on other medical conditions and medical comorbidities, the higher the risk of the transplant would be. Other things to consider in terms of transplant and age. So many of my patients tell me, well, I'm 70, am I too old to be considered for a transplant? If their disease risk is high risk and it's worth getting that evaluation. And this recent study that has been presented a couple of months ago at the annual annual ASH meeting, or American Society for Hematology meeting in December of 2020, looked at one of the bigger studies to consider transplant, whether a patient has a donor versus no donor. And the survival really doubled for our patients who proceeded with transplant between the age of 50 to 75. So based on this study, I would say any patient up to the age of 75 should really be highly considered if they have a higher risk disease to consider an allogeneic transplant. Now, going through an allogeneic transplant isn't an easy procedure, but I think getting the conversation started and getting that consultation with a transplant physician is definitely worthwhile. And then if the patient does not prefer that and doesn't want to go through that, that's totally okay, and that's dependent on what every patient's goals of therapy are. But getting that evaluation and consultation and getting the knowledge and education about what a transplant is, how it looks like, is definitely worthwhile in this patient population. And even I know some institutions even consider a transplant up until the age of 80 on a case-by-case basis. So that really increases the amount of patients who can proceed with transplant. And we have some alternative donor options that are considered nowadays. So kind of putting it all together, what does that mean in reality for patients with lower risk MDS? What are we looking at? So we're looking at initially the International Prognostic Scoring System in its revised version. And then if we determine that we are dealing with lower risk MDS or lower risk disease, we look at what blood counts are actually affected. Is it anemia only that's the issue, where my patient is needing frequent blood transfusions? And do we have that deletion 5q abnormality, and do we have that SF3B1 mutation or the ring sideroblasts? And based on those, we determine the next step in the management. So what treatment options do we have for patients with lower risk MDS? And those include erythropoietin stimulating agents, or ESAs, and that depends on the endogenous hormone levels. So EPO, or erythropoietin, is a hormone that's secreted by our kidneys and signals our bone marrow to make more red cells. If that level in the blood to begin with is low, then adding more of this hormone by those shots, which are the darbepoetin or epoetin alpha, boosts the bone marrow more and helps us improve the hemoglobin level, and it makes sense. However, for those patients whose kidneys are really working really hard and the hormone level in the blood is very high, usually 500 is our cutoff, then adding more and using those shots doesn't really help for most patients. And the response rates tend to go down from 74% when the hormone level is low, all the way down to 7% only if the kidneys are working really hard and making a ton of that erythropoietin in the blood before starting this therapy. The other medication that's FDA approved for specifically MDS with a deletion 5q abnormality is lenalidomide. And this medication is a pill that's taken on daily basis or on a 3-week on, 1-week off basis. And what it does is it improves the hemoglobin or the red blood cell response. And that can happen in 67% of patients. So 2/3 of patients who get started on this medication get a benefit. And the duration of responses tend to be quite long, in excess of 2 years, where patients don't need a single transfusion in over 2 years. And whenever we see those responses, they tend to be pretty quick. Usually within the first month of therapy, we see a very nice improvement in the hemoglobin levels, and patients no longer need to be dependent on red blood cell transfusions. Now, the side effect with lenalidomide that are most common is that it does improve the hemoglobin, but also worsens the platelet and the neutrophil count. So it's not an ideal medication for someone who has pancytopenia or low neutrophil, low platelets, and low hemoglobin levels. Lenalidomide is oftentimes used off-label in patients who do not have the deletion 5q abnormalities. So it's not FDA approved for this indication, but there was a large study that evaluated lenalidomide in patients who do not have the 5q abnormality and saw that the responses are still close to 26-27%, so about a third of patients who don't have a deletion 5q still benefit from lenalidomide. And given that it's a pill option, it's usually an appealing option for many of our patients. And we usually would try it, and it is part of the National Comprehensive Cancer Network guidelines for the management of MDS. And so insurance companies typically have no issues with approving it since it's an NCCN indication. Hypomethylating agents are considered chemotherapy, and those, the FDA-approved ones are the Vidasa or 5-azacitidine, Dacogen or decitabine, and then the new version, the oral version of Dacogen, which is decitabine cedazuridine or Inqovi. This is an oral option that's been approved in the past year, and it's taken for 5 days every 28-day cycles. So there's been a study that looked at using less of the hypomethylating agents because their main approval comes from studies for higher-risk MDS. And the MDS consortium did a study to use less of those to get more cellular differentiation and improvement in blood counts, but we don't necessarily have the high blast percentage that we want to get rid of by using more of those chemotherapy agents. And so this study used a 3-day abbreviated version of the hypomethylating agents, the azacitidine or the decitabine, and looked at response rates. And those response rates were noted to be higher, closer to 60%, as opposed to the 40% that we would expect with the standard dose of hypomethylating therapy. And since then, many physicians in the field usually like to use less of the hypomethylating agents for the management of patients with lower risk MDS. So does sequencing therapy make any difference? So should we use azacitidine first, or should we use lenalidomide first when we have a patient with lower risk MDS? And the factors that I talk to my patients about are, would you want to come to our infusion center and get a shot for 3 days in a row and that repeats every month? Or would you rather try a pill first? And for most patients, oftentimes the answer is, I'd rather go with a pill first and then reserve the shot option or chemotherapy option as the next line. And this study by the MDS consortium also looked at sequencing therapy, and it was found that if you actually start with lenalidomide or the pill option first, oftentimes the response rates are higher than when you reserve lenalidomide as the last resort therapy. Other treatment options for lower risk MDS include immune suppressive therapy, and that includes the antithymocyte globulin, or ATG. The overall response rate is about 48%, but this is a more intensive therapy, so to say. It needs hospitalization for about 4 days, and it usually works best in those patients who have a hypocellular marrow. The most common way the number of cells are in MDS in the bone marrow is we typically see a lot of those MDS dividing and filling up the bone marrow space, and so the cellularity is oftentimes close to 80%, 90%. Only a quarter of patients with MDS have low amount of cells in the bone marrow, and we think the immune system plays a factor in that type of MDS. And so using immune suppressive therapy typically works better for those patients who have the hypocellular subtype of MDS. So kind of in summary, for lower risk MDS, we look at the erythropoietin level in the blood. If that's low, then using those erythropoietin agents, stimulating agents like darbepoetin or epoetin alpha, usually helps with the hemoglobin levels. If we have a deletion 5q abnormality, we consider lenalidomide. And then the most recent approval that we haven't covered is Luspatercept. That was approved in April 2020. And this agent was approved based on this phase 3 medalist clinical trial that used Luspatercept in lower risk MDS who have that ring sideroblast or the SF3B1 mutation. What they've shown is that Luspatercept leads to transfusion independence, so it only improves the red cells and gets our patients off of needing blood transfusions in about 37.9% or close to 40% of patients derive a benefit from it. It is approved in the second line setting, so after erythropoietin stimulating agents. And when it works for an average of or a median duration of 30.6 weeks, or almost 7 months or 7.5 months. So other novel clinical options for lower risk MDS is imetelstat, also in the second line therapy in non-deletion 5q MDS. And imetelstat is a first-in-class telomerase inhibitor that's given as an IV infusion once every 4 weeks. And what they saw from the earlier phase 2 study is that the 8-week transfusion independence was 42%, which is not quite far from what we saw in Luspatercept for those patients who have the ring sideroblasts. And in the imetelstat study, the longest transfusion independence rate was in excess of 2.7 years for one of the patients on this study. And so this is an exciting therapy option. And the phase 3 study is currently open and enrolling, and it's open at multiple sites, and it's an international study open in Europe and the US, currently available at UT Southwestern as well. And it randomizes patients to getting the study drug in 2/3, and then 1/3 of patients will be getting placebo. So one of the downside is 1/3 of patients will get the placebo, but then the majority of patients will get the study drug. in order to improve the anemia responses. So treatment algorithm for higher risk MDS, again, higher risk defined by having a high risk IPSS score or revised IPSS score. And then the first question that we should ask ourselves is, does my patient desire and are they in a good enough shape to tolerate a bone marrow transplant? Do they have a good performance status? And do we have a stem cell donor? If the answer to all of these questions are yes, then we should definitely initiate a transplant consultation, like schedule that patient to see a transplant physician and initiate a donor search. And in the meantime, start on hypomethylating therapy with either azacitidine, decitabine, or the oral version of decitabine, which is Inqovi. If the patient does not desire to proceed with a transplant, or they have a lot of medical conditions that would make a transplant such high risk, then the treatment would still be to proceed with hypomethylating therapy for 6 or more cycles, because the treatment with these agents tends to take time to work. And that time is on average 4 to 6 months or 4 to 6 cycles of therapy. And then clinical trials, given the lack of other therapeutic options, are always important for patients with higher risk MDS. So the outcomes of hypomethylating therapy, how effective is azacitidine and decitabine? And based on the study of azacitidine that was published back in 2009, it showed an improvement in overall survival by about 9 months, with an average or median overall survival of 2 years versus 15 months for those who were treated with azacitidine as opposed to conventional care therapy. That same treatment wasn't seen in decitabine, but they're generally viewed as equivalent in the population, in the general population. And so both are thought of as equivalent hypomethylating therapies. And not everyone responds to these therapies. And so the overall response rates are only in about a third of patients, so 34-35%. And the complete remission rates only occurs in about half of those patients who respond, so 17-18%. So other clinical trial options for higher risk MDS, there's a combination of pevonedistat with azacitidine versus azacitidine alone. This study has been completed enrollment, and we're awaiting the results of the phase 3 trial. If it shows superiority and improvement in survival rates, then that may be the next approved treatment in MDS. There's an ongoing study of magrolimab with azacitidine versus azacitidine alone to see whether the combination therapy is more effective than using azacitidine alone. And this was granted a breakthrough therapy designation by the FDA back in September, because the phase 2 study, the earlier study, showed quite high response rates, about 91% overall responses, with 42% complete response rates for those patients with high risk MDS. And the onset of the response, or the time to respond, was short, about 2 months, as opposed to the 4 to 6 months that we would expect with our standard azacitidine alone. And based on that, there's an ongoing phase 3 clinical study that's enrolling, and it's a multi-institutional international trial that's also available at UT Southwestern for our patients who have higher risk MDS. So when should we consider an allogeneic transplant? And there was a decision model that was published looking at those patients with high risk and low risk MDS. So for our lower risk MDS, transplant up front seems to carry a higher risk than the risk of the disease itself. And so although it can be considered, we usually reserve it until we don't have any clinical trial options or treatment options to improve those blood counts and improve the quality of life. Or if the disease changes from lower risk to higher risk because of worsening blood counts or increased rise in blast percentage or having new chromosomal abnormalities, then an allogeneic transplant or a stem cell transplant does show to be superior or better than not doing a transplant therapy for those patients. And so getting that evaluation is really important for those patients with higher risk disease. So in summary, for the FDA-approved treatment options for MDS, we have lenalidomide for MDS with the deletion 5q abnormality. We have luspatercept for the MDS with the ring sideroblasts or the SF3B1 mutation. And then we have the hypomethylating agents, which are considered chemotherapy, and we have azacitidine, decitabine, and then the oral version of decitabine, which is decitabine with cedazuridine. And then what we commonly use off-label are the erythropoietin-stimulating agents, that be epoietin alpha and darbepoietin, which are shots under the skin, typically given anywhere between every week to every 3 weeks, depending on which formulation we're using. Lenalidomide for the non-deletion 5q MDS, and this is the off-label indication for this pill option. And then immune suppressive therapy, or ATG and cyclosporin for lower risk MDS with anemia or pancytopenia. So how do we put this all together? So when we put it all together and consider all the factors that we've talked about, what do we come up with? And this is the table that I came up with. And when do we do observation? So observation, again, is really important to consider for all patients with lower risk MDS who have pretty good blood counts and do not need any frequent transfusions. And that really can be considered a standard for many of the patients with lower risk MDS. How about transfusion support, or giving red blood cell transfusions or platelet transfusions, or sometimes preventative antibiotics or antifungal agents? This should be a part of the management for all patients with MDS who actually need it, meaning if the blood counts are low enough, then the patients need to have those transfusions to prevent bleeding or to keep the anemia symptoms away, or that fatigue and lightheadedness and other anemia symptoms away. Erythropoietin stimulating agents, and these are the epoietin alpha or darbepoietin. These I would consider for lower risk MDS when the EPO or erythropoietin hormone level in the blood is measured and is low, below 500, and the patient has anemia with frequent transfusions, then I would definitely consider that option. Lenalidomide, it's approved in lower risk MDS, especially for the deletion 5q subtype. However, it is also commonly used off-label for those patients with non-deletion 5q MDS who have anemia. Again, lenalidomide does not improve platelet counts, and it also does not improve neutrophil counts. It only improves anemia when it works. Luspatercept is a shot every 3 weeks. And this is the new kind of approved medication for lower risk MDS with the ring sideroblasts or SF3B1 mutation and anemia. Again, luspatercept is not known to improve platelets or neutrophil counts. Hypomethylating agents, or azacitidine and decitabine, for all higher risk MDS patients, whether they're eligible or ineligible for a transplant, or whether they're wanting or not wanting that option. Allogeneic transplant for higher risk MDS, when the patients are 75 years of age or less and are considering that option, they should get that evaluation and have more in educational talk about what transplant looks like and whether that's a good option for that specific patient. Clinical trial options, always encouraged and always considered at different time points, because as you saw, we don't have too many drugs approved for MDS, and so clinical trials are really the only way to get more therapies available for our patients, and are pretty exciting options when they go into that phase 3 trial or last phase of trial development, where we saw early signals that they do work and that they're safe, and now we're comparing them for the therapies that are available. In the end, I'd like to thank everyone for attending today. I'd like to thank our patients, caregivers, and patient advocates, and the MDS Foundation for allowing me to speak to everyone today. Our bone marrow transplant team at UT Southwestern, our lab collaborators, pharmacy, nursing, research coordinators, and our sponsors. And I look forward to our live Q&A session. Thank you all again, and have a good day.
Thank you for your wonderful, thorough presentation, Dr. Madanat, and thank you all for joining us today. Just as a reminder, for those who haven't sent in your questions yet, you can start submitting your questions in the question box found on the bottom menu bar. Also, if you want to revisit this webinar, you will have full access to it via email and on demand within 10 business days. So let's get started and we'll proceed to our live Q&A. Our first question comes from Ellie. She wants to know, can you have increased blasts without your blood work numbers changing and getting worse?
Yeah, hi, Ellie. This is a great question. And again, thank you to all of our participants for attending today. So increase in number of blasts, that I'm assuming that's regarding the bone marrow blast percent. And that is not an uncommon, but scenario that we actually experience. So in order to do a bone marrow biopsy and make a diagnosis of MDS, there's usually some form of cytopenia or low blood count. Otherwise, the indication for the bone marrow biopsy can be, there should be an indication to do a bone marrow biopsy because it's not a simple procedure. In order to do that, there must be some form of blood count abnormality in order to go ahead and do such a procedure. But if the blasts are increased, and sometimes we see them like 7%, 8% in the bone marrow, and that usually correlates with the disease progressing to a higher blast percentage or a higher risk disease with time. And if you go by the guidelines or ask 10 different people who treat MDS, you may get kind of the answer split in the middle. So some people may, if the counts are really perfect, may watch things but very closely, and others may start hypomethylating therapy to reduce the blast percentage. I think the biggest question is how old is the patient and are they a transplant candidate? And if the answer to both of these questions are a yes, and the patient is considering transplant, we would probably favor doing hypomethylating agent therapy as a bridge to transplant to reduce those blasts and keep them in check until the patient gets a more definitive or curative approach. Whereas if the patient is older, in their 80s perhaps, they feel perfectly fine and they want to just watch things pretty closely, and at the time we notice a blood count starting to change, then at that point we can consider jumping on therapy. I hope that answers your question.
Thank you, Dr. Madanat.
Sure.
The next question comes from Patricia. She wants to know if does the erythropoietin level rise after treatment with ESAs?
Also a great question, Patricia. So typically what, in an ideal situation, we should definitely check the erythropoietin level at the time of the diagnosis and before starting erythropoietin stimulating agents, because those levels can be affected by ESA therapy, and we don't really have a great way of knowing what the baseline EPO level was before starting ESA therapy. So really, before the start of ESA therapy, we should know what the erythropoietin level is in order to determine whether ESA therapy is going to be effective in the first place.
Thank you. We have a comment and a question from Ralph, who has joined us all the way from Indonesia.
Wow.
First, he wants to thank you for your great presentation. And his question is, can hypomethylating agents be used in MDS patients with remaskable cytopenia? His platelets are below 30,000 and his hemoglobin is below 8.
Yeah, that's a great question, Ralph. So in terms of improving all of the blood counts, meaning anemia, thrombocytopenia, and neutropenia or low white cells, hypomethylating therapy is usually the way to go. Again, I would look at the whole picture in terms of the MDS risk and using the revised international prognostic scoring system in order to determine how much of the hypomethylating therapy we should use and whether we should go with the FDA approved label of the full dose in the case of higher risk disease, or sometimes we may consider a little bit of a lower dose when we're dealing with lower risk disease with pancytopenia or low platelets and low hemoglobin.
Thank you. Our next question comes from Michael. He wants to know how relapsing polychondritis is related to MDS.
Yeah, hi, Michael. Also a great question. So there's reports on a relationship between autoimmune diseases in general and myelodysplastic syndromes, and whether these two things can co-occur, or whether the MDS is driving some rheumatologic condition as a paraneoplastic picture, meaning the presence of the MDS led to the development of the autoimmune disease. I think the sequence and the timing is really important to try and help determine the relationship between them. But I would say, the presence of autoimmune diseases, of which relapsing polychondritis is one of them, you would try to target both things, and depending on what the MDS status is, what the blood counts are, what the blast percentage, the IPSS score for the MDS, that will determine your treatment decision for MDS. And then the relapsing polychondritis, obviously we would see a rheumatologist for it, and the common treatment for that is steroids most often. But if that relapsing polychondritis kind of worsens and the rheumatologist is thinking, well, perhaps the MDS is driving all of this as a perineoplastic picture, then in that case, trying to target the MDS may help with the relapsing polychondritis. But I think taking the overall picture and a discussion between the MDS physician and the rheumatologist is really key to determining the best way to approach this situation, because it can be a little bit tricky, and just it needs a lot of communication and coordination. But great question.
Thank you. Great answer. My next question is, what are the chances of finding a donor?
Yeah, that's also a very good question. So nowadays, finding a donor isn't as big of an issue as it was many years back. And the reason for that is, the chances, so there are multiple different types of donors. We usually start looking at a matched sibling donor, so a brother or sister that has the same HLA type, and that's the matching that we're looking for in the DNA or the genetic material. If we don't find a matched sibling donor, then the next area that we look into is through the National Marrow Donor Program, or NMDP. And that's basically a registry from people who would register to donate bone marrows for patients who need them all over the US. And sometimes even we can look into donor options in Europe. And depending on the ancestry or what the patient's original race is, so if patients are from European descent, the chances of finding a matched unrelated donor is quite high in the registry, up to 80%. Whereas minorities and patients of Asian descent or African American patients, those have a much lower chances of finding an unrelated donor in the registry compared to patients from European descent. And the reason is because there aren't as many registered people from those ancestral descents. And then the third kind of option, which we've oftentimes have been using more and more successfully, is to look into children as a half match. And so we call that a haploidentical transplant, or a half matched transplant, because each child gets half of their DNA from one of their parents, or either their mom or their dad. And so that's opened up another line. And then the fourth option, which is we try to avoid getting to that, but if we don't find the related, unrelated, and then a half match, is the cord blood transplant. So finding a donor of some sort, of course, each donor's type has its own risks of long-term complications, and so that's all a discussion with a transplant physician. But finding a donor isn't as big of an issue as it was 10, 15 years ago.
That's good news. The next question comes from Justice. He was first diagnosed with refractory anemia with ring sideroblasts in late 2016. He also has a comorbidity of CLL since 2007. Aranesp failed after 3 years. Luspatercept at all 3 dose levels failed after 7 months and actually worsened his condition. His hemoglobin dropped as low as 6.4, and he became transfusion dependent. 60 days after discontinuing luspatercept, his transfusion levels have increased from 21 to 28 plus days, and hemoglobin after 28 days is at 8.5. He's ineligible for imetelstat because of CLL. He's reluctant to consider lenalidomide or Vidaza. By relying on transfusions alone for the time being, his platelets are also at a normal range. Is this a reasonable approach?
Yeah, Justice, fantastic question. And, this is, thank you for giving me all the details that you have. I can see that you either have done your homework or you have a really good MDS physician taking care of you, because you definitely hit in all the things that I need to know to answer that question, right? So what I would say is, the time at which I would actually consider to start a second line of therapy for a patient is usually about that range. So if someone is requiring more than 1 transfusion a month, that's usually when we actually start considering intervening with therapeutic options to improve the transfusion requirements. But if you're needing a transfusion, once a month, that's usually a tolerable effect with watching for signs and symptoms of iron overload on the heart or the liver. These are the 2 more organs that can be mainly affected with iron overload. But I think that's a very reasonable approach, because I would circle back and say none of the treatments for lower risk MDS were shown to improve overall survival. And so in that setting, any intervention like lenalidomide or azacitidine that we're doing is to really improve your quality of life and decrease the transfusion burden. But if that transfusion burden isn't high enough, sticking to a transfusion once a month, if that's all what's necessary right now, is really important. I would also add that looking for other factors of anemia is also important, to not always blame the MDS and search for other factors such as vitamin mineral deficiencies and copper deficiency, other things that may worsen the anemia and sometimes can be correctable with replacements, is also important periodically, depending on what the exact, other lab parameters are showing, or if there's any concern for that. The last thing I would add, talking about the imetelstat, one of the criteria to actually get onto that trial is you have to have more than 4 units of transfusions within an 8-week period, meaning you have to have at least 1 unit every 2 weeks in order to really justify having the high transfusion burden and needing treatment for it. So along the lines of your question, that if you're needing 1 unit every month and you're from a symptom standpoint, you feel okay, then I think that's a very reasonable approach.
Thank you.
Sure.
The next question comes from Kathy. She's the caregiver for her husband who has high-risk MDS. He started venetoclax combination therapy with Inqovi. His counts are going up. She wants to know, does it also work on blasts?
Yeah, hi, Kathy. So I would say this is not an FDA-approved combination, but it is currently in clinical trial doing this oral combination. And the data coming from getting that approved comes from acute myeloid leukemia. And so the HMA with venetoclax combination is really very effective in reducing the blast percentage in acute myeloid leukemia with quite high remission rates. And so that, between hypomethylating therapy and then the addition of venetoclax, to answer your question, the simple answer is yes. That's really a very effective way to reduce the blasts. I would just say it's not an FDA-approved combination at this point, but they are looking into that in clinical trials because it's a promising combination.
The next question is from Ellie. How often do you recommend a bone marrow biopsy?
Yeah, so that's a great question, and it depends if we're dealing with lower risk disease versus higher risk disease. And so I'll answer lower risk first. Lower risk disease, I usually check I don't check it routinely. I check it at diagnosis, and then before each time we're switching therapy to ensure we're still dealing with lower risk disease and things haven't changed. Or if the counts change drastically, or I'm seeing a lot of blasts where I'm concerned for progression from a lower to a higher risk disease. In higher risk disease, I usually would check it at diagnosis and then around the 6-month mark after starting hypomethylating therapy, because up to 80-90% of patients who are going to derive a benefit or a response do so by the 6 months after azacitidine or decitabine or Inqovi therapy nowadays. So higher risk and lower risk can be different in terms of when to check a bone marrow biopsy.
Thank you. The next question is, if a patient already had a bone marrow transplant years ago, who is now 65 plus, is that person still eligible for an allogeneic transplant? The patient is currently low risk.
So I'm assuming that the MDS relapsed and that's why they're considering a second transplant. So I would, anytime the MDS comes back after transplant, it's not, we won't have a lot of data to support what we're doing, but I would say if the MDS is low risk, meaning the counts are quite preserved, there's evidence of MDS in the bone marrow, I would say it's a discussion with the bone marrow transplant physician. A second transplant for someone who's 65 is definitely a possibility, but the ideal timing to do so can be variable, and that needs to be like a close discussion with a transplant physician. But I would say it is possible if that's the right thing to do. The timing of it needs to be thought carefully.
Thank you. Greg wants to know, is there a typical progression cycle from low risk to other risk categories?
Yeah, that's a great question. So what I would say is the majority of patients with MDS, so the two ways MDS can progress is one by kind of becoming more high risk or going to acute leukemia, which happens usually in about a quarter of patients. And then the most common scenario in 3/4 of patients is a drop in blood counts, whether that's the red cells alone or other blood counts. So worsening blood counts can elevate the IPSS risk, but that doesn't mean that the patient has a high blasts or is going to AML. And that, I would say, is the most common way the MDS progresses, is by worsening blood counts with time rather than going to acute myeloid leukemia or AML, which happens in a quarter of patients. And obviously the risk of the MDS up front, so higher risk disease has a slightly higher chance of going to acute myeloid leukemia, lower risk disease has a lower chance of going to acute myeloid leukemia. And just as a small distinction, the definition of acute myeloid leukemia or AML is basically when the blasts reach a threshold of 20%. But what I tell my patients is 19% versus 21% is really a disease classification, but it's not any different from a biological standpoint, right? But when we reach the 20% threshold, that oftentimes open up other clinical trial options for AML, whereas 19% we're still talking with higher risk MDS. So the therapeutic options on clinical trials can vary based on the blast percentage, but in reality, the disease just becomes more aggressive or rapidly growing.
Thank you. The next question comes from Candace. How do you choose a hospital for SCT? Should it be one that does more SCTs?
Yeah, so and SCT, just to clarify for the rest of the audience, is stem cell transplant. And so choosing a hospital, I would, choose a part of the hospitals that are part of the transplant society that have a higher volume and have experience, because going through a donor transplant or an allogeneic transplant is not an easy process, needs a lot of follow-up, needs close monitoring for toxicities, side effects, things like that. And so it's really, really important to feel comfortable with your transplant physician and with the center that's treating you. I would choose the closest big center or big academic center for an allogeneic transplant for sure.
Thank you. The next question from Marcella. Are erythropoietin agents and blood transfusions the only options for sideroblastic MDS in a 95-year-old woman diagnosed in 2019?
Yeah, I would say, it all depends on the functional status of the patient rather than the age. And Luspatercept is also an option after ESA therapy stopped working. If a patient has been on ESA therapy for longer than 4 months at the highest dose, meaning at the optimal dose, oftentimes switching off to second-line therapy with Luspatercept is what I would favor than keeping the ESAs and keeping the blood transfusions, because the purpose of therapy is to get someone off a blood transfusion. So if they're still requiring blood transfusions despite being on the highest dose of the ESA therapy, then the treatment is probably not helping that much.
Thank you. The next question is from Neil. Can an MDS patient whose hemoglobin level is at 10 live well at Santa Fe 7,000 foot altitude?
Yeah, that's a great question. So in terms of living well, I would say that's dependent on the patient's symptoms and what the patient is, how the patient is feeling. So for someone who has been living at that altitude for quite a bit of time, their body takes the first few months may be more challenging, but then once they've lived there for a period of time, then the body kind of balances out and they get used to a higher altitude. So I would base that off of the patient's symptoms than based on something I would be able to answer.
Thank you. The next question is it reasonable if low risk and not eligible for ESA treatment or the clonal agents treatments to continue getting transfusions every 3 weeks with chelating agents rather than going in the direction of clinical trials or the hypomethylating agent treatments?
Yeah, again, that's a great question. I would say, it depends on the actual subtype, and if there is, room to use Luspatercept, if there is room to use lenalidomide, if there is deletion 5q, then the response rates are probably higher. Once every 3 to 4 weeks is kind of the area where we start considering therapy, because with time, what will happen is that the transfusion requirements will likely go up, and at that point, the patients can consider therapy. But if the patient feels well, has a good quality of life, and is happy with a unit of blood every 3 weeks, and that's maintaining the blood counts, again, taking the overall picture is really important. How the patient is feeling, what their blood counts are doing, and what's the goal of therapy for that particular patient. What's their age, what's their IPSS risk, and taking all of that into account. But for someone who's lower risk, older, has a good quality of life with a transfusion every 3 weeks, that's very reasonable.
Thank you. John is asking, what is the name of the drug you mentioned that's enrolling for clinical trials? And he wants to know, do you know if the Seattle Cancer Care Alliance is participating? I would,
John, I would refer you to the clinicaltrials.gov to look whether a particular center has the trial open, because clinicaltrials.gov will have all the clinical trials in the United States and all the centers that have that clinical trial. The two drugs that I've mentioned in clinical trials is one for lower risk MDS, and that's the imetelstat study. And perhaps we can put that in the chat as the name of the drug. It's called imetelstat, and it's a telomerase inhibitor. The other one that I've mentioned for higher risk MDS is magrolimab, and that's a CD47 inhibitor. The reason I mentioned these two trials is because they're both in late stages of development. So they're both in the phase 3 portion, in which case they're trying to prove that they're more effective than the standard of care therapy. But we still don't have the results from them, and that's why they're still in clinical trial phase.
Thank you. The next question is from Susan. You mentioned magrolimab starts showing improvement in about 2 months. What does that improvement look like?
Yeah, that's a great question, Susan. The improvement, again, that's derived from the patients with higher risk MDS when it's combined with azacitidine chemotherapy. And the results that we have are from the phase 1/2 trial, and now that it has gone to the phase 3 portion. And so the improvement are in the complete remission rates, and that means improvement in blood counts and decrease in bone marrow blasts to less than 5%. So anytime we talk about improvement in MDS, we're talking about two things. If we're talking only about lower risk MDS, that's improvement in blood counts. If we're talking about high risk MDS with a high blast percentage, then we want to knock down those blasts below 5%. So that's one improvement. And if we can also improve the blood counts, then that's kind of the win-win situation that we hope for all of our patients. And that's the complete remission rates.
Thank you. The next question is from Pamela.
Yeah.
Her doctor tells her she's in the low to intermediate risk with possible CMML, but her second bone marrow was not definitive. She's been receiving frequent blood transfusions, and initially her EPO levels were too high for Procrit, but eventually the counts came down below 500. So her doctor started her on Procrit and decitabine IV therapy hourly, 5 days a week, every 5 to 6 weeks, depending on her lab counts. She will be coming up on her 5th treatment. Her question is, should we pursue transplant if she's healthy otherwise? She's 65 years old and no comorbidities, or do we just observe off the medication for a while? Also, her doctor started her on decitabine and she's not high risk. So if she progresses, does she need to go back to decitabine or go to azacitidine?
Yeah, so hi, Pamela. This is your question shows a lot of understanding of the disease. And I'd say what I would probably try and get this bone marrow reviewed at a academic center just to get a second opinion, since it wasn't conclusive, just to confirm the diagnosis. And it's never a bad idea to get a transplant consultation and a transplant evaluation for when things progress, or when the disease changes, or when we're left with no more standard of care clinical options, and if clinical trials weren't an option, then that whether a transplant is a possibility or whether that's something you're interested in. So getting a transplant consultation is never a bad idea, especially, and for CMML, which we didn't cover in a great depth, it does have its own scoring system and systems, and some of them are based on blood counts, but others are based on molecular abnormalities or genomic abnormalities with the gene panel testing. So I think to simply answer your question, I think it might be a good idea to just get a transplant consultation and get the pathology reviewed or confirmed. If the bone marrow, wasn't particularly adequate, they may consider just repeating one to confirm the diagnosis, make sure we're dealing with the right things. And then the decision to stop decitabine or not, it all depends on what the benefit in the blood count. So it's very, this is a very specific question, and I think you need to look at all the blood counts. When you first started decitabine, what were they? How did they change? Has the anemia gotten better, worse? What was the white count? There's just a lot to this that I think this webinar may not be able to answer, but the simple answer for a transplant consultation is it's never a bad idea to get that going and learn more about the process.
Thank you. Our next question is from Marcella. She has elevated erythropoietin levels after 2 years of therapy on Retacrit, Procrit. Is there a concern?
What I would say is I wouldn't care that much about the erythropoietin level while you're on therapy, because as we've mentioned before, those drugs can raise the blood levels of EPO. And so what I care about more is how is the hemoglobin doing? Are you needing transfusions while you're on while you're on the Retacrit or Procrit, and how do you feel? Those are the 3 questions to answer. I would not pay too much attention on the erythropoietin level while you're getting those medications.
Thank you. And Ralph wants to know, what do you recommend as a starting dose for erythropoietin?
Yeah, so that's, so there are 2 formulations in the US. So one is called epoietin alpha, and the trade names for that are the Retacrit and Procrit, and that's usually given weekly. We typically would start, at 40,000 units per week, but can go all the way up to 80,000 units per week. And so we want to use the least effective dose. Same thing applies for darbepoetin, and the trade name for that is Aranesp. The nice thing about it is it can be given every 3 weeks. And so, but because it's more expensive, not all insurance companies like to approve that upfront. So we can use that every 3 weeks and can go up on the dose up to 500 micrograms, and we can even do it every 2 weeks if it's not working after a couple of rounds. So it depends on which erythropoietin stimulating agents we're using. There are different dosages and different dosing regimens between weekly to once every 2 weeks, once every 3 weeks.
Thank you. First, Greg wants to thank you for your great presentation. His question is there any correlation between MDS and NXG, necrobiotic xanthogranuloma? And if so, what is it?
Yeah, that's a really good question. And this, again, is not a very well documented correlation, but it goes along the lines of the relationship with autoimmune diseases, and that's what needs to be determined in terms of whether they're 2 separate processes or whether one is aggravating the other or contributing to its recurrence.
Thank you. Next question is from Maureen. Her hematologist wants her TP53 mutation status tested. Can you explain the relevance of this? She has del5Q and she's on watch and wait, but with decreasing hemoglobin levels.
Yeah. So the P53 mutation is a high-risk mutation in MDS in general. And so I think what your hematologist is trying to get at is they want to really better understand the risk of the MDS that you have. Oftentimes we're able to get a full gene panel test via a method called next generation sequencing, and P53 is one of the genes that is on that panel list, but what they're trying to do is to get a better understanding of the risk of the MDS that you have. So if that wasn't tested, the full NGS panel, if it wasn't done, it's something that, nowadays has become standard of care to get that in order to better understand the risk of the disease. And once in a while, if we're lucky to find a targetable mutation, then there are that opens clinical trial options to try targeted agents for a particular subtype of MDS.
Thank you. The next question is there any way to replace a deleted gene? And are there any studies underway on that would help an MDS patient?
Yeah, that's a great question. And I would say there is a way to modify a genetic mutation, or when it's a single base DNA change. That in MDS has not been fully studied, but the areas that this has been explored is mainly in sickle cell disease and other diseases where the etiology of it is a simple change in DNA, which can be edited, and that tends to help the disease process. In MDS, the issue is a lot more complex, we think. So right now there aren't any clinical trials, and I think it might be a difficult process because it's not only one gene deletion, but it can be multiple issues and multiple mutations that accumulate with time until the disease presents as MDS.
Great. The next question is from Karen, who has Del5Q, and she wants you to explain again the pros and cons of choosing EPO or Revlimid first, and also, would you choose Revlimid first, or if you chose Revlimid, can the patient then take EPO later?
Yeah, the answer to that is yes and yes. And the way I would choose is I would let my patients choose between them and explain to them, the benefits of each approach, whether they want to come and get a shot. I usually try and get darbepoetin approved just because it's every 3 weeks initially. And so getting a shot once every 3 weeks versus taking a pill once a day is the difference between them. And, for the particular subtype of deletion 5q, we know that the chances of the Revlimid working are quite high, around the 70% mark. But then if the EPO level is also quite low, then the ESA therapy, the chances of them working is also at similarly high. So and we don't really know if you use one before the other, then that makes a whole lot of difference. So they're both good options. Whether you start with one and move to the other, or the other way around, is both acceptable.
Thank you. The next question is, can you discuss relationship between MDS and kidney failure?
Yeah, so MDS per se, there isn't like a direct relationship from the MDS on the kidneys per se, but again, along the lines of whether there's an immune-mediated component or another renal-related issue. But if the blasts increase, so for example, in acute myeloid leukemia or AML, if we see a lot of those blasts in the peripheral blood, those can sometimes cause direct damage to the kidneys. But if we're not seeing any blasts and there's just MDS in the bone marrow, there isn't really a direct relationship to kidney failure or kidney damage.
Thank you. The next question is a transplant question from Maureen, who wants to know, is a haploid match better than a matched unrelated donor?
It depends. I would say it depends on the transplant physician and the transplant center and what their preferences and experiences are. So I can share the UT Southwestern experience. We typically, if we have a fully matched unrelated donor, we would go with that first. But if we don't have a fully matched unrelated donor, then we look into haplotransplant options. But every transplant center has their own standards and experiences, and so that really depends on who you're talking to and who the transplant person is.
Thank you. Anna wants to know, what are the stem cell transplant from adult stem cells?
Correct. So most of our donors are above the age of 18, and so they're from adult stem cells, right?
The next question is, what are the risks of a high ferritin level, 2,800, over time with transfusions of 1 unit every other week? XJ causes some discomfort and it has been reduced to every other day. What is the recommended dosage for XJ to reduce ferritin to an acceptable level?
Right. So this is a particular situation where I would try and look for therapies for the MDS to try and decrease those transfusion burden and kind of take care of the issue itself, than to try and just fix the ferritin level, because the MDS is ultimately leading to the increased transfusion needs, which are leading to the high ferritin, which may lead to kind of the iron overload toxicities over time. And so XJade and the iron chelating agents are not the easiest to tolerate, and they can affect the kidney function amongst others. So I would say I would try to focus on the MDS treatment that would decrease the transfusion requirements, and that would ultimately help take care of the underlying issue that's leading to the every other week transfusion.
Thank you. I think we have time for one more question. And this is from Michael, and he wants to know, how would you choose a hospital for a second opinion?
Yeah, so I would use the MDS Foundation website. Is a great resource for a lot of the MDS centers of excellence in the United States. And so if you want a second opinion in person, choose the closest to you. And if you want it as a telehealth visit, which is possible these days, then you can choose anywhere you'd like. But I would choose an MDS center of excellence and would rely on the MDS Foundation website. That's a great resource for all of our patients that I refer them to.
Thank you. I think we actually have time for one more question, if we could slip it in.
Yeah.
How is it determined whether a patient should have a bone marrow transplant versus a stem cell transplant?
Yeah, that's a great question. I would say, there isn't any difference in these are two interchangeable words that we use in the transplant world, but the stem cell source can be derived from peripheral blood stem cell collection or from a procedure called a bone marrow harvest to collect the stem cells. But ultimately, a bone marrow transplant or stem cell transplant are somewhat interchangeable in the transplant world. And the way we collect those stem cells, whether it's from an apheresis machine that collects the stem cells from the peripheral blood, or whether through a bone marrow harvest, doesn't make a whole lot of difference. There is advantages, disadvantages to each particular approach that the transplant physician typically would discuss. But oftentimes nowadays, most of the stem cell collections are happening through peripheral blood stem cells because it's a less invasive process for the stem cell donor to undergo and donate the stem cells.
Thank you. Unfortunately, that's all the time that we have for questions. Thank you, Dr. Madanat, for your wonderful presentation and your time. I also want to thank everyone for attending today and for your great questions. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. If you missed out or would like to revisit this webinar, be on the lookout for an email that will provide you with a link within 10 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes today's program.